Hey everybody, so today we're going to be covering Chapter 30, Musculoskeletal Trauma. In this chapter we're going to review what the musculoskeletal system is, just a brief overview of it. We will also discuss about various injuries that we may see to bones and joints, go over the basics of splinting, as well as go over what non-traumatic fractures are. So the injuries to bones, muscles, joints are very common, and sometimes they can be potential, or for the most part, minor, and just a minor nuisance to the patient. Some can be life-threatening, however. So our care of these patients, which we will go over in this chapter, will be to uh, how can we prevent any further damage of the injured extremity. Now, our musculoskeletal system is what shapes our body. It was allows our organs to be protected, such as in our rib cage. It protects our greater vessels, our heart, and our lungs, and our cranium, and our cranial skull. That's protected by our skull. Is our brain as well. Um, with the assistance of joints and ligaments, or excuse me, with the assistance of ligaments and tendons, it allows for us to be able to move and be able to walk around. It helps with the production of red blood cells within the bone marrow of our bones, such as in the humerus and the femur, as well as storing salts and other materials that's needed for our body to be able to function. Now, there are three types of muscles within the body. You have your voluntary muscles, which are the ones that you are actually able to move, such as balling your fist into a hand, balling your hand into a fist, would be controlling your voluntary or skeletal muscles. Your involuntary muscles, these are those ones that are in your organs, such as your intestines, your esophagus, the ones that you don't have to consciously think about to control. And then your cardiac muscle, this is your heart muscle, which it has its own capabilities as well. Now, muscles can be injured in many ways. Overexerting a muscle can break muscle fibers, and muscles subjected to trauma can be bruised, crushed, cut, torn, or otherwise injured, even if the skin is not broken. Muscles injured in any way tend to become swollen, tender, painful, or even weak. Just like muscles, tendons and ligaments can be bruised as well, crushed, cut, or torn, and they are included in the category of musculoskeletal injuries. Tendons connect muscle to bone, and ligaments connect bone to bone. Now, your cartilage, it acts as a shock absorber between bony surfaces. Kind of, so that way as you're walking, for example, the cartilage in your knee ensures that your femur and your tib fib aren't rubbing against each other. Now, your cartilage can be injured as well, potentially leading to joint pain. As I said, ligaments connect bone to bone, tendons attach muscle to bone. Now, in a sense, this is kind of like a glue that helps hold the body together. If one of them gets torn, stuff comes apart. As the body's structural framework, the skeleton must also be strong enough to provide support and protection, as well as jointed to permit motion. So within the structure of a joint, you have your joint capsule, that helps keep the synovial fluid within that joint cavity in there. That helps act as a lubricant for everything as well. Now, there's 6 types of motion that the skeletal system can do. You have flexion, which allows you to move your extremity towards the body. You have extension, that is a bending motion that moves the extremities away from the body. Adduction is moving a body part towards your midline. Abduction is away from the midline. Rotation is when you turn the body along the axis of a bone or joint. And circumduction is movement through an arc or a circle in a circular motion from a central point. So like doing arm circles. Your axial skeleton, this is your head, thorax, and vertebral column, and your appendicular skeleton is your extremities, shoulder girdle, and pelvis. And we break this down into 6 basic components. You have the skull, spinal column, thorax, which is your chest, chest and abdomen. You have your pelvis, lower extremities, and upper extremities. Within the skeleton, there's approximately 253 bones. Don't quote me on that because I don't have my book right in front of me. But anyways, there are certain ones that you want to be aware of. Those are the ones that you've already been tested on, such as where the femur is, and the humerus, and the patella. Your upper extremity consists of your shoulder girdle, your arms, forearm, and hands, and the bones of such as your clavicle and scapula, your carpal bones, your radius and ulna. Your lower extremity is made up of the pelvis, thigh, leg, and foot, including your femur, all 4 bones of the pelvis, the tibia and fibula, and the tarsals, metatarsals, and your phalanges. Now, a fracture is any kind of break within the continuity of a bone. Just like how you have a laceration is a break in the continuity of the skin, a fracture is that break in a bone. Now, when a bone becomes fractured or if it becomes displaced, this can cause potential damage to surrounding tissues such as nerves, blood vessels, muscles, tendons, ligaments, anything that may be around it. It can be open or closed depending on whether or not it breaks through the layers of the skin. Now, osteoporosis, this is a degenerative bone disorder that's usually associated with some loss of minerals, primarily calcium from the bone. When a patient does have a fracture, there are a variety of signs and symptoms that they may see. They will be very painful. They may have paresthesia distal to the fracture site, which is a tingling or abnormal sensation. Usually this would be indicating some type of nerve injury. Paresis or weakness, paralysis, a decrease in pulse amplitude, increased capillary refill time, pale cool skin distal to the fracture site can indicate blood vessel damage. There's also a variety of fractures that you might see also, such as a green stick fracture, which is basically the bone has just splintered, excuse me. It's a minor fracture. Usually they can just put a simple cast on it or brace it and let it heal on its own. Impacted fracture, this would be caused by, for example, you falling onto your feet, and because of the impact and all of your weight coming down on that bone, it fractures that way. Spiral fracture, this would be caused by you twisting and causing an overexertion of that twist, and it causing it to spiral fracture that way. Comminuted, that would be where the bone is broken up into multiple different small pieces. This is usually caused by some type of severe trauma, gunshot wound, for example. Oblique fracture, this is just when the bone fractures at a 45-degree angle. This can be caused by a fall or some type of trauma as well. And then a transverse fracture, this is a fracture across the parallel plane. The closed and open fractures, closed fractures, like I said, are the ones that don't have that break in the skin, whereas open fracture is one where it causes also a break in the continuity of the skin. So not only do I have a fracture here, but I have a fracture within the skin as well. Now, just because if it's open, it does not mean that the bone end is having to stick out. It could have receded back into the injury site. Now, when you have a fracture, it can be quite disturbing, and where it takes all of your tension away. Treat the injury, splint it, but remember to take care of your ABCs as well. Okay, stabilize it in the position found. Splint it using your SAM splint, and immobilize it and transport. Now, if it's an open fracture, such as you have here, where the bone end is protruding through the skin, once again, it's very disturbing. It's going to take your attention away. But unless you see arterial blood squirting out of it, there's not much that we can do. Ensure that your ABCs are okay. Splint it in the position found. And transport the patient. Even a deformity would be a kind of fracture. This would be a sign of a fracture. Complications of fractures include hemorrhaging, bruising, any kind of bleeding into that area, which would indicate a break of a blood vessel, tissue damage of the surrounding areas, infection, as well as interruption of the blood supply, because if the tissue is damaged, even if blood vessels aren't actually broken, they may be pinched off to where now it's not allowing blood flow to go through. So if we have a fracture and we have loss of PMS, you can attempt one time to realign. But if the patient is complaining of too severe of pain, or if you're unable to realign it, leave it alone, splint it in the position found. Now, a strain occurs when those muscle fibers are beginning to tear, or they have become overexerted. Usually, there won't be any no edema, there won't be any swelling. The patient will just be hurting. They may have mild to severe pain. Whereas a sprain, now we're affecting the actual joint capsule, so now we're usually affecting the ligaments. These injuries, if there's an injury to a ligament, usually you'll see there will be swelling and bruising, discoloration. The patient will have severe pain right away. Your shoulder, knees, wrist, and ankle are the joints most vulnerable to sprains. The patient typically experiences immediate pain and tenderness in the joint upon injury. Now, the patient is complaining of pain and tenderness at the site of dislocation and typically is unable to move that extremity. A dislocation is dangerous because it could damage blood vessels and nerves by compression or tearing. Now, if we have a dislocation, no matter if it's to the knee or to the joint, we are to do not attempt to relocate it. That is not our position. We can cause more harm than good. Now, the force applied to the body can cause injuries to the surrounding soft tissues, even to body areas that are distant from the injury site, as that energy or that force progresses through. Always make sure that you assess your mechanism of injury as well as the signs and symptoms. Make sure that they correlate along each other. In all of these fractures, most of these injuries, though will be presenting with similar signs and symptoms, if something odd for a musculoskeletal injury is presenting, generally it means that something else has become affected. So a mechanism of injury for an injury to a bone or joint, you can have a direct force, where you have a fracture directly at the point of impact, such as being hit with a baseball bat in the upper arm, and you have a fracture of the humerus. An indirect force would be an injury impacting one end of a limb, causing injury a distance away, such as you falling straight down onto your heels off of a tree. You may have fractures to the calcaneus, but indirectly may have caused fracture to the femur, your hips or pelvis, or even your lumbar spine. Twisting force, that's when you plant and you continue to twist. So that extremity remains stationary. So let's say, for example, your foot remains planted, your body continues to twist, and because of that twisting force, you have a fracture of the tib fib, or your tibia fibula. Now with the femur and pelvis, these could potentially be life-threatening because these specific fractures to these two bones are associated with a high incidence of serious bleeding and the potential for the patient to develop shock. A fracture of the femur or pelvis is considered a critical injury and must be managed not only to immobilize the bones, but also to reduce any associated bleeding. The bones of both the femur and pelvis contain a large blood supply. When fractured, these bones tend to bleed very heavily. Also, the bones are near other large vessels that might be lacerated by the bone ends, leading to serious bleeding. If you have a traction splint available and you only have a suspected midshaft fracture, you have no fracture distal to there, such as in the lower leg or ankle, and you don't have a fracture of the pelvis, we can apply the traction splint. What this does, it pulls traction on the leg to realign the bone ends, which prevents further injury and reducing pain. It also reduces the size of the thigh, which allows less blood to accumulate and indirectly puts pressure on the bleeding bone ends. Within this area, just within the femur alone, the patient can lose up to 1,500 milliliters of blood within each femur. That's just with a femur fracture. You throw on top of it a pelvic fracture, and you're bleeding into the pelvis, the patient can bleed out over half of their blood supply because of the size of the pelvic space before you even realize it, and can easily lead to the patient's death. Within the bone, specifically the femur and pelvis, you have your marrow cavity where arteries are running through to feed the bone. Because remember, the bones are still living organisms. They need an active blood supply. But it's also where production of red blood cells are beginning. But our red blood cells, part of it comes from bone marrow. When assessing injuries, you go through it just like you normally would. Usually, most of these will be found during your secondary assessment. Now, if the patient is unresponsive and there are multiple injuries or the mechanism of injury is significant, you want to conduct a rapid secondary assessment. If you're doing a rapid secondary, you want to check for deformity, contusions, tenderness, decap BTLS, any swelling, discoloration, or open wounds at the site of the injury. Assess the skin temperature, color, and condition. Assess the pulse and check capillary refill time distal to the site of injury. Now, if they are responsive, have a single injury, and the MOI is not significant, such as falling off a bike, you can do a focused assessment and hone in just on that injured extremity. Now, even though we may suspect a fracture in the field, we cannot definitively diagnose that patient with an x-ray. They have to be taken to the hospital to where they can get an x-ray done and verify it. Now, they will have severe pain associated with the fracture. This can distract the patient from complaining of other more significant pain, such as abdominal or spinal pain. For this reason, fractures are referred to as distracting injuries. Now you keep hearing me say a mnemonic such as decap BTLS. We use this for assistance with our trauma assessment. Which stands for deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. Okay? Look for any of those signs and symptoms that you would expect with a bone injury, such as bruising, deformity, tenderness, grating or crepitus, that joint locked into position, or even exposed bone ends. You want to assess for the 6 P's, which is pain, pallor, paralysis, paresthesia, pressure, and pulses. Pain may be found on palpation or with movement, with or without movement. Pallor means that the skin distal to the injury site is pale, as well as capillary refill delayed if an artery is compressed or torn. If a vein is blocked by the fracture, the distal extremity can appear warm, red, or flushed and swollen. Paralysis, this means that the patient is no longer able to move the extremity. This might be caused due to nerve, muscle, tendon, or ligament damage. Paresthesia is a complaint of numbness or tingling. The patient may complain of a pressure sensation within the extremity. This may be associated with swelling due to damaged tissue or blood loss within the muscle and surrounding structures. And you also want to assess for pulses distal to the injury, because these may be absent or show a decrease in amplitude, and which would indicate damage to an artery. If the patient has a life-threatening condition caused by or directly related to the extremity injury, such as a femur or pelvic fracture with hypotension, or an open fracture with severe bleeding, immobilize the injured extremity during your primary or secondary assessment if the appropriate resources are available, and it does not cause a delay in transport of the patient, and then transport the patient immediately. If the patient has multiple fractures, or if they are severely unstable, or even if you're suspecting inline stabilization, you can place the patient on a long spine board, secure all extremities into the straps, and that can suffice as sufficing as a full body splint until you can get them into the truck, get everything else done, and then you can go through and splint the individual fractures. You can also apply cold packs to the area as well as elevating the extremity. This will cause vasoconstriction and reduce blood flow to that injured area to help reduce any potential swelling. Repeat your vitals. Make sure that you reassess PMS, or pulse, motor function, and sensation. And you want to note whether or not they have improved or if they have deteriorated because of immobilization. Alright, splinting, we use this to ensure that joints or bone fragments or ends are unable to move, or at least prevent them from moving, so that way we can reduce any further injury by the patient moving around. It also can assist in reducing any pain, because now the patient's not moving around that affected extremity, irritating the affected area. And also prevents any complications such as further damage to the blood vessel. Also causing conversion of a closed fracture to an open fracture, causing excessive bleeding or increase in pain. Now, a splint is any device used to immobilize a body part. It can be soft or rigid, and it can be commercially manufactured or improvised from virtually anything around. If the patient is showing signs of shock, align the patient in the normal anatomical position, if you're able to. Treat the patient for shock, transport immediately without taking the time to apply a splint. If a fracture of the femur or pelvis is suspected, splinting should be considered as a bleeding control measure. Splint the femur or pelvis at the scene only if enough resources are present so that a delay in transport does not occur. Make sure you cover all wounds. Pad under each splint so that way it's more comfortable for the patient and reduces the likelihood of pressure sores forming. If you're having to hold traction, hold that traction until the splint has been successfully applied. Now there's a variety of splints that are available. Rigid splints are those that are manufactured commercially and is made of such as wood, plastic, cardboard, or some type of compressed wood fiber. Some are designed in specific shapes for arms and legs and are equipped with Velcro closures. Others are pliable enough to be molded to fit any appendage, such as a SAM splint would be considered a rigid splint. Air splints, these are soft and pliable before being inflated, but once they are filled with air, they become rigid. Air splints cannot be sized and can impair with circulation and interference with the ability to assess pulses and lose or gain pressure with temperature and altitude changes. Traction splints provide a counterpull, alleviating the pain and reducing blood loss and minimizing further injury. These are not intended to reduce or correct the fracture. Formable splints are a type of rigid splint, i.e. your SAM splints, that is malleable enough to conform to a deformed or angulated extremity. The splint is shaped to the deformed extremity instead of making the extremity fit the splint. Once shaped to the injured extremity, it is fixed and placed with either cravats or Velcro straps. These are usually made of wire, thin aluminum, or some other metal that can bend. Vacuum splints are soft, pliable splints that are easily formed to deformed extremities. The air is then sucked out of the splint, causing it to become rigid in its position of placement. A spine board or a full-body vacuum mattress is a full-body splint. In the case of a critical injury when extremity fractures cannot be splinted at the scene, placing the patient on a spine board or in a full-body vacuum mattress will provide some stabilization through the limitation of movement. This is not an ideal method of splinting, however. Uncomplicated fractures are not a priority in critically injured or unstable patients. A vest-type immobilization device, or KED, is sometimes turned upside down and used to splint a suspected pelvic injury. And you also may be forced to improvise at the scene. Improvised splints can be made up from pretty much anything, such as cardboard boxes, a cane, ironing board, rolled up magazine, umbrella, broom handle, catcher's shin guard, or any similar object. An ordinary bed pillow or blanket roll can be an effective improvised splint when wrapped around the area and secured with several cravats. Some splints are more suitable to certain types of injuries than others, but many are interchangeable. Follow your local protocol in such cases. The general types of splints, I'm going to try to point them out for you, are your rigid splints, your air splint is back here, your vacuum splint is over here, traction splint, your improvised, and then your spine board. Now, there are multiple types of traction splints that are available, so make sure when you get working in there, wherever you go to work in the service, make sure that you are familiar with how to properly handle your traction splint. We'll try to get this out in class, that way y'all have a base idea of how to use these. But for the most part, they're all the same. You have one strap that goes around the ankle, a ring that will hook up to your S hook. These straps will go around the fracture. So one strap goes above the fracture. This one goes below the fracture. You never want to strap on top of the fracture. This one will go just below the patella. And then this one about midway down their lower leg. You want the winch approximately 2 to 3 inches past the ankle. Once you hook your S hook to the D ring, all you got to do is just winch it until the traction is starting to be pulled, And you'll get an immediate response from the patient once it's doing its work, because they'll go from ow, 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 ow to ooh, that feels better. Now with anything, there are possible hazards. For all the obvious benefits to the patient with a bone or joint injury, they can cause complications if applied in the wrong manner. The main one being causing a delay in transport. If the patient's critical, splint en route. If you don't pad correctly, it can cause degradation of the skin. You can aggravate the injury and cause excessive motion if you're not careful. It can also cause compression of nerves, tissues, and blood vessels as swelling continues. That's why it's important that when you splint, that you test pulse, motor, and sensory functions before and after splinting, and when you go to reassess. Splint in a functional position if you are able to. If you are not able to get it back into a normal position or into a functional position, splint in the position found. If the distal extremity has become cyanotic or lacks pulses, as I've said, align the joint with gentle fraction. If pain or crepitus increases, stop what you're doing. Do not spend time trying to differentiate a joint injury from a bone injury, because it may be difficult to distinguish between the two. For both, you need to splint and transport. Signs and symptoms, be aware of those, such as pain, swelling, deformity, immobility, and loss of function. Just like with a bone injury, assess PMS below the injury site before and after splinting. Traction splinting, this reduces the diameter of the thigh, decreasing space in which bleeding can occur. It helps tampen out the bleeding area, relieving the pain, and reducing incidence of internal injuries that would occur if the patient were transported without immobilization of the injured extremity. Remember that you don't have to be certain the femur has been fractured. If the thigh is painful, swollen, or deformed, you should treat the femur as if it is fractured. Do not use it if the hip has been injured or the pelvis is fractured. There's been any injury to the knee, or if the injury is within 1 to 2 inches of the knee or ankle, or if there is partial amputation or avulsion anywhere within that leg. Make sure that you familiarize yourself with the proper splinting techniques for settings such as the upper arm, elbow, forearm, wrist, hands, fingers, pelvis, hip, thigh, knee, lower leg, ankle, and foot. For some of this, you're going to have to work with what you have. Some of it is pretty easy to figure out how it needs to be splinted. With a pelvic fracture, we can use a commercially made pelvic binder or splint, or we may even improvise our pelvic wrap with a sheet to splint and stabilize the fracture and tampen on any possible bleeding. We may also use what's called the PSG, or pneumatic anti-shock garment, which is basically pants that's no longer used commonly anymore, but you could use those, put them on, and just blow up the pelvic portion of it, and it would give that splinting as well. If you don't have a commercial one and you're having to make an improvised pelvic wrap, you want to fold a sheet lengthwise into an approximately 8-inch width. Slide it under the small of the patient's back, and then slide down until under the pelvis until it is centered and the ends of the sheet are of equal length on both sides of the patient. Cross the tail ends over the patient, twist them until the sheet is tightly secured around the pelvis, taking care to avoid any folds coming into contact with the skin and creating pressure points. Once that's done, tuck the sheet ends under the patient or tie the ends into a square knot, and then place the patient on a backboard or some type of rigid device for transport. Make sure that you could go through and do a proper reassessment, because when we splint, or even as swelling continues into an injured area, you can have compartment syndrome due to it. Now, we may not see the compartment syndrome. This is something that is often develops over time, so we may not see it. And what's happening is that pressure within that injured area continues to grow and is exceeding the capillary pressure needed to perfuse the tissues, thus causing them to become hypoxic, which results in further damage and swelling. The patients will complain of severe pain or a burning sensation, particularly with movement. When you go to palpate the extremity, it feels very hard because of that swelling. You may even have tearing of the skin as well because of it. You may have paralysis of the extremity, decreased strength within the extremity. However, distal pulse PMS may be normal. So if you have compartment syndrome in the upper arm, down in the lower in your hand, it may be fine. So that's why you want to make sure that you do a full assessment. With a pathologic fracture, these are the ones that don't require trauma. Signs and symptoms associated with non-traumatic fractures are similar to fractures caused by trauma. However, these do not present with obvious evidence of trauma to the area of fractures, such as contusions, abrasions, lacerations, and hematomas. Care for non-traumatic fractures is the same as for that caused by trauma. During your assessment, ensure the underlying medical condition is not producing any life threats that must be managed. These can be caused by osteoporosis, benign bone conditions such as congenital cysts often suffer from pathologic fractures. Just by simply walking and, someone bumping into something or just walking can cause a fracture. Alright guys, that completes this chapter. If y'all have any questions, please be sure to write them down or send me a message in Blackboard or in Remind. If you have any, make sure that you are doing your Brady Labs. And if y'all don't have any questions, I will see y'all next time in class.